Good evening all, and welcome everyone to the faculty talk conducted by IRIA Kerala in association with JournoMed. And for this, I welcome Dr. Gomati Subramaniam, President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, and Dr. Ramesh Shanai, Program Coordinator. And today the program is being moderated by Dr. Anish, Associate Professor, Malabar Medical College, Calicut. I welcome Dr. Anish. And our faculty is Dr. Tina Sleeba, Senior Consultant, Department of Radiology, Rajagiri Hospital, Kochi. Hearty welcome, Dr. Tina Sleeba. And now over to Dr. Anish for the introduction of the speaker.
Yes, sir. It's my honor and pleasure to introduce to you our faculty today, Dr. Tina Sleeba. She'll be showing us few interesting cases on breast imaging. She's working in Rajagiri Hospital, Aluva, for over 8 years. She is involved in academic activities and also resident training in Rajagiri Hospital and also in webinars and all. Her area of interest is breast imaging and interventions. She is in charge of breast imaging and intervention at Rajagiri. So I welcome again Dr. Tina. Over to you. You can start the session.
Thank you so much. I think Tina can share the PPT. Oh, okay. Is the PPT visible to everyone?
Yeah, it's visible.
So, very good evening to everyone. Happy Vijayadashmi. And thank you IRIA Kerala for having me take this session. Like I said, I had told Dr. Gomati it was an extremely short notice. So what I have done is I have taken a few of my interesting cases which I had presented in the past, kind of mixed and matched, and just trying to present a few things which I believe might be of clinical significance and interesting for residents and people who would like to practice breast imaging. So there are a few series of cases with an interesting take-home message. So I think we'll start with that. So I'll call the first series a mismatch series, where we look into what really happens when we have an inappropriate assessment. That means a BIRADS category assigned to a particular report, and the recommendation, I mean, what ideally should be done for that BIRADS, they don't match with each other. So a few cases on that note. So this was a 45-year-old who underwent an ultrasound for a newly detected right breast mass lesion. I'm pretty sure the age and the history should actually start ringing bells in one's mind. 45-year-old with a new, at that age, you really don't expect something new to be coming up. Hormones are actually waning. So something new should always be dealt. I mean, you should be dealing with it with a little caution. So this is the ultrasound that was done outside. And this was given as a likely fibroadenoma. Now going back to the image, the ultrasound image, definitely an ovoid circumscribed lesion, but a closer look at the internal echo texture. Is it really homogeneous as we see in fibroadenomas? Not really. And if you look at the margins somewhere maybe around here or maybe somewhere on this aspect, it's not very distinct. And I don't really have the Doppler images. It was done outside. So this was given as a likely fibroadenoma BIRADS 3, meaning the person doing the scan believes that it is possibly benign 98 to 99% of the time. So, okay, that's one bit of the report. What happens when they go ahead and give this recommendation, advised excision biopsy? That means possibly the thought process is there's something not quite right about this lesion. Though it looks like a fibroadenoma, it's not really a fibroadenoma from all angles. So this is where the person advising, giving a recommendation for this BIRAD went wrong. And another thing to note is there was no baseline mammograms done. So unfortunately for this patient, it turned out to be a grade 3 invasive ductal carcinoma. And the margins were positive, meaning the surgeon actually sliced through the tumor and axilla was unaddressed. Axilla not addressed means basically every malignant case needs to have an axillary sampling, even if the patient is clinically node negative, or on imaging itself you really cannot see any metastatic nodes, but nevertheless the axilla has to be addressed always, because that's how the surgery for breast cancer is undertaken. And nodes are the single most important factor which determine how this lady with breast malignancy would do in future, her disease-free survival, overall survival, things like that. So this was a CT chest we undertook just to see if she had, in retrospect, anything else going on. And this is, the irregular cavity in the upper outer quadrant of the right breast. That was a seroma. And this, of course, was a very sinister looking metastatic node. So nodes not addressed just because it was called 3, but was advised an excision biopsy. Next case, a 41-year-old lady. She had, she said her left breast was increasing in size for 8 months. She gave another very significant history. 15 months prior to that, she had undergone a excision for a left breast lesion, which is pretty big according to her. But what she had right now was much bigger. So this was the ultrasound image taken from outside, and it was fairly big to begin with. It's pretty obvious because it was taken on a curvilinear probe, and the person doing the scan has raised the possibility of phylloids, which seems like a most probable diagnosis. It's an ovoid circumscribed lesion with vascular spaces and gradually increasing for 15 months. This was given as Barrett's 4, meaning it should ideally be sampled. But again, this is what recommendation. This was a recommendation that went along with the assessment, advised excision biopsy. So unfortunately, this lady went to a small time center where a surgeon said, okay, we'll go ahead and take it out, because as soon as they hear that something is wrong in the breast, the next thing they want is to meet someone who would say, okay, I'll take this out for you as soon as possible. So this is exactly what happened. Unfortunately for him, he really didn't know what he was dealing with. It was pretty big. All he could do was take a piecemeal excision. The lesion was completely violated, and the final pathology in their hospital was given as possible borderline phylloids. So one thing about phylloids or sarcoma anywhere in the body, what we need to remember is that this lesion doesn't treat breach very well, meaning if you cut through a sarcoma, they tend to come back in a very, very aggressive manner. And this is exactly what happened. 15 months later, she came back to us with an entire breast replaced by this phylloides tumor. And this, of course, was a malignant phylloids. We really couldn't do anything to save her breast at this juncture. 65-year-old, new onset right breast mass lesion. So first investigation of choice ideally should be a mammogram. And yes, that was what was undertaken for her. So you see, part circumscribed and part obscured lesion, high density, right breast, upper outer quadrant. This was given as Barrett's 4B, meaning the radiologist felt that it could be, 50%, it could go either this way or, that way. It could either be malignant or it could be benign. And again, a wrong recommendation, advised excision biopsy. So she did undergo an excision biopsy at another center. And then after the lesion was removed, this time the margins were all clear. But then she came back to us because now, of course, we needed to put her on chemo. And then we realized that she had a whole lot of metastatic nodes, which was not addressed in the primary surgery because the surgeon didn't go in expecting malignancy. Then, of course, this was how her CT looked like. She had metastatic mediastinal lymphadenopathy, cervical adenopathy. That was a lytic lesion in the bone. So this patient ideally was not a surgical candidate to start with. So metastatic disease at presentation. So 55-year-old with pain in left breast mass lesion. And now this was reported as a suspicious mass, was given a Barrett's 4A, meaning less than 10% chances of it being malignant. A closer look at this lesion, I don't have the Doppler images, but then these margins really don't look good. They look microlobulated, heteroechoic internal echo texture. And in a 55-year-old, clinically, if it's hard, it's nothing but malignancy. Again, patient was advised an excision biopsy. Excision biopsy, and this came back as a grade 2 invasive ductal carcinoma. Again, the issues that we had was axilla was not addressed, and she did not have a baseline mammogram, which should be the first line of investigation at her age. So when she comes back to us for further management, we start off with taking a baseline mammogram for the breast that is involved and for the contralateral breast. And this is what we see, surgical clips and this tiny focus of microcalcification. So this is a closely grouped focus of pleomorphic, a lot of different calcifications in different shapes. So she had a very concerning focus of high-grade DCIS extremely close to the surgical site of surgical excision. And this is something which we can tackle only using stereotaxy. This was not visible to the naked eye on ultrasound. We did a stereotaxy. This was high-grade DCIS. And then she proceeded on for complete mastectomy on the involved site. So the points to take home from here is an appropriate recommendation should always follow the assessment category that we assign. If it's a Bayes 3 that you're giving, it means 98 to 99% of the time, you're pretty sure that it is not a malignancy and you're dealing with something benign. But if there is, an iota of doubt that this lesion possibly is not, a completely fibroadenoma or not completely benign, it should always be upstaged to at least a 4A and a sampling advice. Sampling, what we mean by sampling here is a core biopsy, because like the previous cases that I showed, excision can be a total disaster. And if you are a center that is not dealing with, biopsies, you don't do core biopsies, kindly refer them to a place that does that. Because unplanned and unskilled surgery can be extremely disastrous for patients. We see them on a regular basis. And the point to remember, residents, is breast cancer surgery is incomplete without an axillary sampling. In cases who have, clinically node negative disease, or you really cannot see anything on ultrasound, these patients still undergo what we call a sentinel node biopsy to see if at all there are any metastatic nodes. So breast cancer surgery is just not removing the tumor and coming out. The axilla has to be always sampled. Another thing to remember is do not recommend what we call a close follow-up, maybe a 1 month or a 2 month follow-up. If you're not sure it's a suspicious lesion, please refer them for a core biopsy, because not all patients come back for your close follow-up. Many are lost to follow-up and come back in really pitiable states later. So the take-home point is the only real mistake is one from which we learn nothing. So this is primarily for residents. You need to know that your, assessment and recommendation have to be in sync with each other. The second series that I would like to show is DCIs with a difference. Here we would be dealing with a not so, commonly heard of entity, that is a non-calcified DCIs, and how do these look on mammograms or on ultrasounds. So I'm pretty sure all residents would be very familiar with these kind of images. Now, this is a very closely grouped focus of pleomorphic microcalcifications, highly concerning. This is a regionally distributed, what we call linear branching. Again, a 4C on mammogram, highly concerning for high-grade, DCIS. And this is like a linearly distributed pleomorphic microcal, all classically dealing with calcified DCIs. So what about non-calcified DCIs? How do these look on imaging? So the first case is that of a 60-year-old. She had actually come in for a health checkup mammogram, and she gave a classical history of gradual increase in size and heaviness of the right breast, and there was no prior imaging, neither ultrasound or a mammogram. And this was like one of my cases from 2016 done on an analog system. And this is what we see, a global increase in density on the right side as compared to the left. So what are we dealing with? This tiny lesion out here is an intramammary node. So this was not of major concern, but the global increase in density. So are we dealing with some kind of a mastitis? The patient was absolutely cold. She had no symptoms, no redness of skin, nothing. Look at the skin. Look, skin is absolutely, normal compared, I mean, if you compare it with the contralateral side, again, are we dealing with inflammatory breast cancer? Again, that has, we know, symptoms mimicking mastitis. So nothing really to suggest that. And she's not received any radiation. She's not in any kind of systemic failure or fluid overload state. So just global increase in density with the skin and, nipple areolar complex fairly looking okay. And what is most important then is that we really didn't see any microcalcifications within the breast on the right side. So we take her for ultrasound, and this is what we see: multiple tiny subcentimetric, microlobulated lesions with little bit of indistinct margins. And we see this, the tissue, the echogenic tissue surrounding these lesions. It's usually when you have a malignancy, a larger malignancy, you tend to see this. But then this breast was riddled with these tiny subcentimetric lesions with this kind of a fuzzy indistinct margin and no much vascularity. So we knew that we were dealing with something, it was not benign. This is possibly some kind of DCIS or invasive disease. So we went ahead and did a biopsy, and this is what the biopsy report came as: DCIS with cribriform pattern. That's kind of an intermediate type of ductal carcinoma in situ. And this was her images on MRI. The diffusion out there, the entire breast involved by this neoplastic process that was going on. And she underwent a mastectomy, and she had a very tiny focus of invasive carcinoma. This was what her final stage was, T1A disease with no lymph nodes. Very interestingly, this patient didn't receive radiation at that time. We really don't know what happened. This was possibly not discussed in the tumor board at that time. She was, lost to follow-up. She came back, I think, last year with small, deposits back on the chest wall, and she's now doing good. I mean, she's back on chemo, and radiation was given to the chest wall. She's doing good now. So second case is that of a 45-year-old with recurrent episodes of left breast nipple discharge. Now, this was blood-stained, 45-year-old, and this is what we see: a linear, asymmetric tissue extending from the nipple, a short segment. It's not very long, at least on CC, but on the mediolateral view, we see it extending all the way till about the pectoral. And this is what we see on ultrasound: a thin, a fluid-filled duct with extremely thickened walls, echogenic walls, and this had some bit of vascularity. So since we could see this finding on ultrasound, we proceeded with doing a core biopsy, guided core biopsies. Multiple samples were taken from along this duct, and we did get atypical ductal hyperplasia. That's a high-risk lesion. And whenever you get a diagnosis of ADH on one of your cores, there's always a good possibility that it might get upstaged on an excision. So we really couldn't stop at that, because we knew there was more to the disease than that was seen on ultrasound. It was going all the way to the pect. We knew we were on the right track. We had at least ADH on core. And so we proceeded with doing a breast MRI. And this is what we see: a linear, a clumped enhancement involving the lower outer quadrant of the left breast. And this indeed was a high-grade DCIS. So she underwent a wide local excision of that involved area. And this was a micropapillary ductal carcinoma. And so the micropapillary variant is notorious at times for, presenting with multicentric disease. More than one area of the breast may be involved. And finally, she was given adjuvant RT radiotherapy, and she is currently on hormonal treatment. So this was a 58-year-old on surveillance right mammogram. Her left breast was removed, secondary to past history of malignancy. And this tiny lesion out here in the right breast had been there in most of her, priors. It had been there for about 3 to 4 years, but maybe 2 years back, when we took her surveillance mammogram, this is what we saw. This lesion started showing a few specks of calcifications. Now, you could say this could possibly be a fibroadenoma, which is like showing degenerative calcifications right now. Very possible. Good thought, could be, but this is what we get when we do a spot magnification view. We get to see a whole lot of round and if you punctate calcifications, a little bit of linear distribution, and this was not very concerning. We told her we could either put her on a very short-term follow-up or go ahead and do a biopsy. Unfortunately, this was a lesion that could be seen on ultrasound, and this did have a slight microlobulated margin with vascularity. Still it was not very definite. It could still have been a fibroadenoma with early calcifications, but core biopsy of this revealed a ductal carcinoma in situ, a low-grade variety, and then she, of course, underwent a guided excision following MRI. A 65-year-old on surveillance mammogram. This is what we see 2016, 17, and 18. There is a new focal architectural distortion that had developed in our upper outer quadrant. We really couldn't see this finding on ultrasound. There was some tissue thickening out there, and we did a core which came as negative. So she subsequently underwent a stereotactic biopsy of that, vacuum-assisted biopsy of this region, and it was ductal carcinoma in situ. This is a 48-year-old lady who came in for a diagnostic mammogram. And if you look at her left breast, there is obvious malignancy out here. There is a whole lot of pleomorphic microcalcification, and she did have mass formation in this region. But what is concerning is on her contralateral side, there is this focal asymmetry, which is better seen on the mediolateral oblique view as it tends to fall away from the rest of the breast tissue. So this was left breast malignancy with metastatic nodes, and this focal asymmetry was seen as this mass lesion, again with microlobulated and indistinct margins. We did a core sampling for this. This turned out to be a high-grade lesion. This was actually a atypical ductal hyperplasia. There was no evidence of DCIS on the final pathology. So a word about non-calcified DCIS. About 80 to 90% of DCIS presents mammographically as microcalcifications. That's how you pick them up on your mammogram. But 10 to 20% might be non-calcified. So you really cannot, see them. But why it's so important to document these is because when a surgeon is doing a limited resection or a conservative surgery, his margins might come positive if there is non-calcified DCIS which has not been documented. So how are these normally seen on mammogram? Sometimes as high as 1/3 of the cases, you might really have no finding on mammogram. At times, they might present with diffuse breast densities, distortions, circumscribed lesions, and tubular densities. We've seen all of these in the examples that I showed. And what you need to remember is on ultrasound, they can present as circumscribed lesions, but the margins are a little microlobulated, and they may or may not show any appreciable vascularity. If this is of concern in a patient who is a high risk, or if it's a new finding in someone who is postmenopausal, you need to look at these lesions a little more carefully. So MRI, in fact, depicts the true extent of the disease, and that is mandated. It's a mandatory requirement before these patients go in for a definitive surgery. So this is one last case just to wind up. A 54-year-old lady with severe back pain and lump in the left axilla. So this is again one of the cases from 2017. So right and left breast, lesion out here, upper inner quadrant. She's got huge nodes in the left axilla. A closer look at that lesion. It's actually a sub-centimetric, primary breast malignancy. It's just about 9 millimeters, but it's got a whole lot of sinister looking microcalcifications, pleomorphic, amorphous, everything in that. This was actually a breast primary, and this is what the patient's CT looked. So her bone was riddled with metastasis. Another case, why I'm showing these two cases is, I'll come to that in a short while from now. So this is another lady who had some blood-stained nipple discharge, and she had very indistinct areas of high density within her right breast. A spot mag revealed a lot of areas of closely grouped pleomorphic microcalcifications, and this is what we saw on ultrasound. We went ahead and sampled this because this was the largest sinister looking area, which is about 1.2. We knew this was definitely malignancy because many patients with what we call HER2 disease or women who are HER2 enriched, who have HER2 enriched malignancies tend to have this diffuse infiltrative kind of tumor in the breast. And so we went ahead and sampled this. This was invasive ductal carcinoma, and she was the HER2 enriched subtype. And this is what we see on her, abdomen. This is taken from her PET-CT images. You see a whole lot of umental caking. So nothing really happening in the breast except for some, microcal and some vague symptoms of nipple discharge, but the extent of disease is far more than expected, finally when we get to imaging. So size really doesn't matter when it comes to breast cancer, because what residents need to know here is this is a reason why we ask for a core biopsy, because we need to know what type of breast tumor are we dealing with. Not all tumors are of the same type. There are different subtypes like, luminal A, B, HER2 enriched, triple positive, and of course, triple negative breast cancer. So you need to know what you're dealing with, because some tumors, even if they are small, they have the potential for having metastasis at diagnosis. So please do not, go by a lesion size, but the nature of the tumor might be a little more different on immunohistochemistry. So ideally, a new case should undergo a core biopsy and what we call an immunohistochemistry for subtyping what tumor it is. So that's all for today. I think any questions I'm glad to take.
Ma'am, Venu sir, you there?
Any questions are there in the chat box?
I have a question for you, Dr. Tina. Can you shed some light with respect to the BIRATS grading, especially the grade 0? Okay.
Grade 0 is when we usually, we try our best not to give a grade 0, definitely at least on a screening mammogram. Grade 0 is when we say that, you really need more information, as in maybe a prior to suggest whether this finding that you're seeing on today's mammogram was existent or not. We try our best not giving a grade 0. Okay. In case if it is given, it ideally should carry, an info from the person who's reading. The radiologist should mention the reason why it's being given as a grade 0 and what and all you would need, maybe a prior mammogram or any prior biopsy reports which the patient would have had, but just forgot to bring them along when they came into your institute for a mammogram. So that has to be written in detail at the bottom, so that, there are clear instructions to whoever. If she goes back to a clinician, he knows why it was given as a BIRATS 0. So most commonest indication is when we want a prior.
Okay. So another doubt, like with respect to 0 only, if you find a lesion, okay, if you are seeing a lesion on mammography and correlative ultrasound,
okay,
but you are not sure, like, it could be, like as you said, tiny lesion.
Okay.
It may be looking benign, but you have a doubt that it can be malignant.
Okay.
You can say if she had a family history of breast cancer, or the opposite breast is already operated.
Okay.
But a tiny lesion is there. So in that case, you are you think that the patient may need MRI.
Okay.
So in such scenario, what grade to be given? Whether it could be grade 0 or like
no. The thing is, what BIRATS Atlas says is that in case if there is a doubt as to what this lesion is on ultrasound or mammogram, you need to assign a BIRATS on your first primary screening modality. If it's if it's a mammogram, you need to give it a 4 because you're not very sure what it is. It could possibly be malignancy. What if this patient doesn't turn up for a for an MRI breast? So what BIRATS says is that you need to assign a assessment category based on your mammogram and ultrasound report, saying if it is concerning, she needs to undergo sampling. An MR can be done as an adjunct, and that later on you can possibly give a combined report. But it should never be that, you give a BIRATS 0 on your mammo and ultrasound and then advise an MRI later. What if the patient doesn't come back for an MRI?
Yes.
So she just goes with a feeling of a fall. Yeah, that it's possibly not malignant. So we would be wrong there. So ideally, it should carry an assessment on mammo itself.
Initial, yeah. Okay, good point. Thank you. Venu sir, anything more to add?
Actually, Dr. Tina, the way you presented now actually seems very good. First, you showed a few cases, and based on which actually you are deriving certain points, and so that the points will be just entering into the minds of the viewers now. So in that way, it's good.
Thank you, sir.
One thing in mammogram for the residents now. In mammogram, actually, we are looking for two things.
Sure.
One is opacity. Any opacity is there. Second is any calcification is there.
Sure.
If opacity is there, you just characterize the opacity, whether it is dense opacity or soft opacity, and also the margins of the opacity, whether it is irregular or microlobulated or macrolobulated, spiculated and all.
Sure.
Depending on which you are putting it as either as benign or malignant.
Sure.
And similarly, calcification also benign calcifications or microcalcifications, malignant calcifications. So the typical microcalcifications, malignant calcifications you beautifully showed. And so one should be familiar with the malignant microcalcifications. So just one point for the residents that, see, the spotty calcifications are not microcalcifications. Again, I am repeating it. Spotty calcifications, that is dot-like calcifications, are not microcalcifications. Truly speaking, they are microcalcification, but it is not malignant calcifications. See, malignant calcifications are actually are small calcifications, maybe 1 to 3 millimeter in sizes, but they are having certain shapes like linear or V shape or C shape, like that. Some shape will be there, and also it will be something like the density is something like chalk powder. No, it is somewhat like hazy. Is not very bright. No, if you come across very bright calcifications, then these are not malignant calcifications. So here you might have noted that these calcifications, these malignant calcifications, are a little hazy. So one should be familiar with the important point is one should be familiar with the microcalcifications. So two things, one is opacity, second is calcification. So only these two things we are looking in the mammogram. And then if something is there, of course, associated findings like nipple retraction or skin thickening or axillary knots or increased vascularity or architectural distortion and so on. When an opacity is seen, we usually correlate with ultrasound. So ultrasound again will tell that whether this is benign or malignant, whether it is cyst or solid lesion. If it is solid lesion, whether it is benign fibroadenoma or malignant lesion. So ultrasound is actually complementary to mammogram. So mammogram is not complete, or there is no point in reporting mammogram alone without doing ultrasound. So that is one point. And second is then where actually the mammogram scores. So mammogram scores in detecting the microcalcifications. See, no other imaging modality as of now, no other imaging modality detects microcalcifications. Neither CT nor MRI nor ultrasound nor just X-ray. No other imaging modality detects microcalcifications. So only mammogram. So that is why mammogram is considered as a screening tool. Because when you go for screening, mammogram screening, actually the patients are asymptomatic. So there won't be any symptoms and there won't be any signs. There won't be any lump. No, nothing will be there. So in that case, actually we expect only calcifications. So at that time, you straight away you subject the patient for mammogram. But the thing is that now the problem is that everybody knows that actually mammogram is the standard imaging tool for breast. But the thing is that whatever comes with whatever the patient is having symptom, immediately the patients are sent for mammogram. Actually, it is not needed. So suppose the patient presents with abscess or mass lesion, in that case, it's not the mammogram that the patient should be subjected to first. The patient can be sent for ultrasound. So ultrasound, suppose it shows a cyst, mammogram is not needed. If it shows a benign solid lesion, again mammogram is not needed. If it shows an abscess, mammogram is relatively contraindicated, because when you do mammogram, you will be giving compression that will be very much painful for the patient. So first the ultrasound, followed by mammogram if necessary. If you are suspecting malignancy, in that case, to rule out again calcifications within the lesion or outside the lesion, as sometimes you can get satellite microcalcifications. For that, you can send the patient for mammogram. So that is actually diagnostic, for diagnostic purpose now. There the patient is having symptoms, the patient is having signs. So in that case, if lump is there or whatever it is, nipple discharge is there, or pain investigation, is ultrasound followed by mammogram if necessary. At the same time, if the patient comes for screening mammogram, there the case, mammogram is the imaging weapon that we have got. And if mammogram shows, picks up something, in that case, we can go for ultrasound. So there, mammogram followed by ultrasound. In diagnostic, for symptomatic patients, ultrasound followed by mammogram if necessary. Anyway, it's very good, because actually, I think the residents are not actually exposed to mammogram. Many times the institutions may not be having mammogram, or even the mammogram is there, they may not be exposed to them. So it's better actually you be familiar with some lesions, main lesions like cyst, how it looks like, how cyst looks like, or how fibroadenoma looks like, or how a malignancy looks like. And if possible, oil cyst or galactosile or lipoma. So these are the common pathologies that we come across in breast, and also the node. So whether the node is significant or not. And along with that, if we can master guided FNAC or biopsy, then that's enough, isn't it? So there is no point in actually giving a report alone, and there the patient will be at loss. So many times we may have to get a histological diagnosis, for which we have to do guided biopsy or FNAC, as most of the lesions would be sub-centimeter in size. The clinically it may not be palpable, or sometimes the lesion may be deep-seated. In that case also, if you do blindly, you may not get it, or the targeting may not be correct, optimum. So in that case, it's better to go for guided FNAC or biopsy. In exam also, maybe as a spotter or sometimes a short case, this mammogram may be put up. Okay, thank you very much. Thank you, Dr. Tina.
Yes, we have few questions. Anish, can you just ask the questions to see chat box? Few questions are there.
I can't see any questions in the chat box.
Yeah, I can see how CT is helpful in the first case. Tina?
CT in the first case, which was a...
That you showed a large lesion. The first case, large in ultrasound it was appearing hypodense with irregular borders. You showed, no? The first case?
Was it the phylloids case that...
I think it was phylloid, yeah.
No, okay. Possibly they mean the seroma. Yeah. Okay, the CT was not undertaken to look at the lesion. That was a seroma. That was a post-excision seroma. That was a seroma cavity. I just put up that image just to show that, that was a site where an excision was undertaken. And then she, along with that, she did have a metastatic node. So CT was undertaken for her because she was malignant, And now we needed to have a baseline screening of a lung, if at all she had any metastasis or not. So NCCT chest is usually undertaken for small lesions. We no longer do chest X-rays for screening. If they have baseline.
We usually do CT. Yeah. When are intramammary lymph nodes to be biopsied?
Okay, so intramammary lymph nodes, if you have a known malignancy somewhere in the vicinity, if the node looks, concerning. So if, for example, intramammary nodes also can look very concerning if the patient has some systemic disorder, like, some kind of lymphoma going. Many a times we see very prominent, scary looking intramammary nodes in sarcoidosis, in lymphoma, in a whole lot of other neoplastic or non-neoplastic conditions. So if there's a known malignancy, you need to put in that information to your surgeon, especially along with the fact that she has other metastatic nodes in her axilla, because that node also needs to come out in case if they're planning, if she's, upfront surgery, or she can be taken up for surgery. She's not a known metastatic case. That node also needs to come out. So that is one. But like I said, in other conditions like sarcoidosis, lymphoma, if you have generalized cause for lymphadenopathy, then you really don't need to sample that. You can just add that in your report. You have prominent intramammary node. Patient is a known case of such and such. In that case, your assessment would be based only on the breast, meaning if her breasts are absolutely normal, except for this node, then you would still call it a BI-RADS 2 and say that this node is part of a systemic disorder. If not, then that node definitely needs to be sampled. If there's nothing, if it's got concerning features, like we speak of nodes anywhere else in the axilla, like loss of nodal architecture, diffuse cortical thickening, eccentric thickening, anything, that node needs to be sampled.
Anish, are you able to see the questions?
Yes, ma'am.
Okay, continue.
When are the dilated ducts suspicious on ultrasound?
When are dilated ducts?
When are the dilated ducts suspicious on ultrasound?
Okay, so if you have a single dilated duct and really don't have anything more to it, that still carries a 30% probability, 13% probability of being DCIS or malignant. So if the patient has a history of a blood-stained nipple discharge or watery discharge, the index of suspicion goes up even further. So single or a single segment or a single quadrant involvement, you need to start getting very cautious. Maybe you're dealing with something here that could be even non-calcified DCS, like the cases that I showed. So, but if you tend to have a perimenopausal or a postmenopausal lady who has, few prominent ducts all around the areola and both breast circumferential prominence, then many times, it's because of what we call periductal fibrosis. As women age, there tends to be fibrosis around these ducts. So these ducts kind of get prominent, slightly more, dilated, and fluid tends to accumulate in them. So if it's symmetrical, bilateral, it's more or less circumferential, all around the nipple, then possibly you don't need to sample them. You really don't have to, you just have to reassure the patient. But single quadrant, a particular segment, these are things which should, raise possible concerns. Then, of course, on ultrasound, if you see duct wall thickening, you see the parenchyma adjacent to these ducts don't look really very healthy on ultrasound, something is going on. Then these are things which should raise, concerns. Are we dealing with something here? And of course, mammogram should be looked very carefully into. Are there microcals involving this particular quadrant where you're seeing dilated ducts? So these are things how you put 2 and 2 together, and then you take a call on whether you really need to sample this, or you at times need to do something like an MRI. In our institute, we actually, if we see something that's concerning, we don't proceed to MR first. We sample them. Once we get tissue diagnosis, we know we are on the right track, then we go ahead and do an MR. We primarily don't do an MR. Many a times, if there's a finding that's concerning, and you can see a finding on ultrasound which can be sampled. So MR is actually kept just prior to surgery, so that the surgeon, we map out the region of involvement for the surgeon.
Right. The next question is, what is the suspicious feature in the first case? I think that is the fibroadenoma case.
The
Yeah.
fibroadenoma, yeah. If you look at that image carefully, can I go back to the presentation or? Okay. What was concerning is that though it was a very ovoid circumscribed lesion, you need to look at the internal echo texture too. So that lesion had few areas of subtle breakdown. If you see, there was some kind of cystic areas in lesion. I didn't have the Doppler picture with me, so I really didn't know if it was vascular or not. But if a fibroadenoma doesn't have homogeneous internal echo texture, you tend to see some cystic spaces in it, and it's showing a little more vascularity than you normally would see in fibroadenomas. Please be very cautious. This could be a triple negative breast cancer. A TNBC looks very much like a fibroadenoma, but tends to have intralesional areas of necrosis, which at times, we have seen it. I have seen it, where you follow up patients on fibroadenomas, and suddenly one fine day, one fibroadenoma starts showing cystic spaces. So, and then when we went ahead and sampled, it turned out to be triple negative breast cancer. So we routinely see malignancies coexisting amongst benign lesions. So any change in character of a fibroadenoma, or if it really doesn't have a homogeneous echo texture, should either be thinking of a phylloids, or please have malignancy should not be out of your thought process. It should be considered. You should be looking at it, especially if it's a young woman, premenopausal. It should be given a serious thought.
Okay, one more question is there. With respect to intramammary node only.
Okay.
If no malignancy in the vicinity, only isolated intramammary node, any size criteria to sample?
Any
size criteria to sample if there is no malignancy in the vicinity, isolated intramammary node.
I really am not very sure if there's a size criteria for lymph node sampling, because even in metastatic nodes, see, you might have a 3 centimeter node which might have a little bit of diffuse cortical thickening and still might not be metastatic, but you might have a 5 millimeter node which shows possibly loss of nodal architecture, or eccentric cortical thickening, which is considered to be a very highly specific sign for metastasis. So things like those are what we look at in axilla. We never go by the size criteria. In intramammary nodes, especially like you said, if there is no malignancy in the vicinity, or they are just considered a Baratz 2 finding, you possibly need to just put it in the body of your report saying there's an intramammary node seen in the upper outer. Sometimes we see it in the lower outer quadrant also. It's quite common to see them there also. Once in a while, we've seen it in the pre-pectoral, coming into the retroglandular area. So nodes are seen. Not all nodes just restrict themselves to the axilla. So once in a while, they wander into the breast, and then you need to take a call depending on these features. Otherwise, it's just a benign Baratz 2 finding, I would say.
But most of the nodes, what I have seen is that they have the fatty hilum, and most often they will be oval in shape rather than round. So once the shape changes, and once you're not going to see the fatty hilum, and if you see vascularity, definitely we are going that it is going to some other change, neoplastic process, isn't it? That's what I feel.
Yeah, definitely. And one other, in some patients, what we can possibly do is look at the contralateral nodes. Sometimes when it's just mildly thickened, a very minimal diffuse thickening, sometimes looking at the contralateral nodes kind of helps us make a decision whether this is metastatic or not, because even metastatic nodes need not have any of the other sinister features except for mild diffuse cortical thickening, slightly more than the contralateral side. Then you're possibly this woman might have metastatic nodes.
Yeah. I think no more questions. This being Breast Cancer Awareness Month, I would like that whoever listening should give awareness about the breast cancer to the public, and the screening process like mammogram should go on. If they are not doing the mammogram, at least try to do ultrasound screening also. Because most of the cases I have seen in my department, a lady coming to our department for screening, and we found out a lesion, but she went without doing any biopsy. She said, I'll come after 1 month. That's the strategy of every patient nowadays. So we have to force them, and we have to tell them also. So those who are listening, I just request that take this seriously and give awareness to the public, to the bystanders in your unit, so that it will be helpful for them. It was wonderful talk, Dr. Tina. Yeah, all the case scenario was very good. Thank you so much. I think we can wind up.
Okay.
Dr. Venu? Okay.
Yes, madam.
Dr. Anish?
Yes, madam.
Yes, yes, ma'am. Dr. Tina, it was a nice presentation with all the interesting cases and a few very important learning points. Very important points. Venu sir also added few more points. So I thank you once again for being part of IRIA Kerala academic program and sharing your experience and wisdom. Thank you.
Pleasure. Thank you so much.
Thank you so much. Thank you.
Okay, I thank IRIA State President Government ma'am, State Secretary Rijo sir, Academic Chairman Venu sir, State Academic Coordinator Ramesh sir, for organizing this session. I also thank all the residents who are watching this program and all the faculties. Thank you one and all, and also the platform, the MedPiper. So next we will be having a topic on breast imaging itself on this Friday. So welcome you all once again.
Thank you so much. Good night.